Welcome to our seminar series that is being put on in partnership between the International Consortium for Regenerative Rehabilitation and the Alliance for Regenerative Rehabilitation Research and Training, ICRR and AR3T. We're really excited to be hosting this part of the Regenerative Rehabilitation seminar series, and the next 4 sessions in this seminar series will be featuring rising stars of the regenerative rehabilitation field. We have 4 excellent scheduled seminars coming up that are featuring a combination of award and career development award winners from previous competitions and grant announcements. Each one of the series coming up of the next 4 will feature a winner from the Lightning Talks competition, which took place in the fall, the Regenerative Rehabilitation Lightning Talks. And it will feature one of the AR3T Mini Career Development Award winners. So please make sure to sign up for the future ones. We have a great series of excellent speakers all around. Today's is March 19th, but we will have one on April 23rd, May 21st, and June 25th. You can find details about those on the AR3T website, and there will be announcements through the art blasts that go out as well. So I am going to, with that, turn it over. So today's speakers, I'll introduce them right before their presentation. Our first speaker is Chia Tai. Chia is a first-year PhD student from Kyoto University and is majoring in human health science. He will be speaking today on a talk entitled Hybrid Model of Scaffold-Free and Silk-Based Scaffold Printing in Regenerative Medicine. Chia was the People's Choice winner of the Lightning Talks competition that occurred back in November, December. So please welcome Chia, and Chia, I will turn it over to you. And thank you again. Chia is all the way over in Japan, so it is midnight for him. Thank you for joining us even at this late hour. We really appreciate it.
Okay, right now I'm going to share my screen. Can you guys see the screen right now?
Yes, we can.
Okay, the screen is moving, right? I just want to make sure before I start to talk. Okay. At first, I want to say thank you for everyone. Thank you for having me here. It's my honor to be here at night in Japan and in the morning in United States. So today I want to talk about my research plan. Okay, I'm going to turn off my video. So the title is Hybrid Model of Scaffold-Free and Cell-Based Scaffold Printing in Regenerative Medicine. So before we start, I want to talk about the background. So most people are thinking about osteoarthritis. So what does that actually look like? Actually, it's inflammation of the joint throughout the body. It's most commonly affect the knee, but it can also affect the knee, the lower back, hips, and hand, etc. There are 3 main symptoms in your joint: pain, swelling, and stiffness. So if you have these 3 symptoms, it might be a high possibility you are suffering from this disease. And with the aging of the population, the prevalence of osteoarthritis is expected to rise. You can see from this graph, the patient is increasing dramatically from 2020 to 2040. When we do it the deeper, osteoarthritis of the knee, which is a situation where you have the knee, they degrades to the point where you are going to have a joint replacement. It's just a wearing out of the joint basically. You can see the cartilage from this paper, from this graph, they start to wearing off. So it's all gone. And the bone and rub together each other, it causes the inflammation after. And we know the knee replacement can help significantly relieve the pain. And right now, it's osteoarthritis and untreatable disease. Do we have any treatment? Can we cure this disease? Of course, yes. And one of the most popular current treatment, what it calls autologous chondrocyte implantation, where you can actually take a biopsy of the cartilage from the knee, and you can send off, get the cartilage cells, which is chondrocyte, and you do the cell culture. And after you go back into the knee a second time, you implant those cells, and then you store a covering on top of that to give you more of a cartilage type of covering across that area that's involved. But there are a lot of complications of the autologous chondrocyte implant. For example, there's an implant failure and knee infection, and also knee stiffness may also occur. So that's all my idea come from. That's why I want to make a new novel approach. And 3D printing is one of the most promising approach used in different fields. For example, tissue engineering and medical field. And also I will do the comparison of the 2D culture and 3D culture. So basically, what's tissue engineering 2D approach? How does it work? So at first, you get the cells from what's the cell of the organ you want to use and implant, and what kind of cell you want to culture, and you try to grow the cells. And after 1 day or 2 days, cell will start to attach the bottom of the petri dish, and that's the first layer of the 2D cell sheet. But if you want to grow an organ, you need a lot of cells. So 2 layer, you need 2 petri dishes. So if you want to do the multi-layer, you need a lot of petri dishes. There's no more 2D cell culture. But why 2D cell culturing is not efficient? Because if you want to grow an organ, for example, you want to grow an cartilage construct, it's kind of like time consuming. You need a lot of petri dish, and you also need a lot of time to grow the cell, and you don't even know the cell, it can be survive successfully. And the spray, the proliferation is really low compared to 3D culture. So that's why 3D culturing become, they are getting more and more attention right now. And how do you make the 3D culturing? One of the most approach is 3D printing. And here there's a kind of 2D and 3D cell culture, the small difference here. In the traditional way of the cell culture, the 2D dimensional culture was the mainstream, but not anymore. 2D culture, like used in many fields, such as medical care, drug discovery, and cosmetic. And right now, 2D is well established and simple, effective method for observing cell behavior with interaction with other cells. But however, it's far from real cell environment. Cell behave differently from its original state in vivo. Also, polarity between the surface and bottom affect the physiological on the cell. So when you try to mimic the human body, so 3D culture is one of the, it's kind of like relatively new and closer to in vivo, physiologically relevant tissue model. And simply saying, the 3D culture is the better way to mimic the real environment. And it's also for close to our human. And that's a material and method I'm gonna prepare in my future plan. At first, when you try to use a 3D printing, the bio-ink is really important. And for the bio-ink, there are a lot of cross-linking methods. For example, the temperature, ionic solution, and also self-assembly and UV light with methacrylate group, and also enzymatic. And here I'm gonna choose, there's one material, it's called Gelma. because geoma, the bio ink, it made up with geoma, hydrogel have more suitable mechanical property and better thermal and therefore are more promising of the cartilage regeneration. This is because of the geoma can form cross-link hydrogel after the thermal initiate or photo-initiate radical polymerization. And they also have a good biocompatibility, tunable property, and also photo cross-linkable via the incorporation of the photo-initiator. So this is how the geoma gelatin mesocalate work. After when you get the gelatin, the gel mesocalate, and you add some lab, some photo initiator code lab, it can be cross-link after. That's how it actually works. So right now, 3D printing is a novel and innovative method for the 3D fabrication of living tissue and organ-like structure throughout the deposition of the small unit. So what's a 3D printing? Actually, when you put the bio ink inside the printer, and the biomaterial and cell can be arranged in various patterns. So for example, for this picture, when you try to print this scaffold, it starts to move and moving. This is the first layer of the scaffold. This is how it works. So after all the bio ink, with biomaterial, they feed through from the nozzle, you can get the first layer. And this idea is also came from the traditional additive manufacturing, which is the traditional 3D printing, layer by layer, and you can make the 3D model. And for here, I'm gonna choose a mesenchymal cell, and for the biomaterial, I will choose a cell fibrin. And why we have to choose a mesenchymal? Because they have a special feature. They have a survival, self-renewal, and also differentiation highly depend on the surrounding ECM. And also there are a lot of material you can put in your bio ink, the synthetic and natural one. For the scaffold fabrication, they can providing a suitable biomaterial which is able to mimic the native to human body. And the later one is called scaffold-free printing. The scaffold-free printing is more like an aggregate, such as cell pellet or tissue strain spheroid, which secrete ECM, like structure holding together the cell component. And I would like to culture the spheroid because the spheroid is one of the first multicellular architecture of life. It can have organ-like function. So they also can be considered a building block of life, like brick in building houses. But they have some limitations here. The time of the pre-printing, the preparation, which tend to be much longer. You have to culture a lot of cells, and a high number of cells is needed to prepare sufficient amount of aggregate. And also the major hurdle with the approach is the difficulty of the making large scale tissue. So there's a pros and cons between the scaffold-based bioprinting and scaffold-free bioprinting. You can see I can combine two of the advantage here. The use of bioprinting is easy to bioprint, easy to make the scaffold, easy to make the extra organ-like pattern, and use the scaffold-free. The advantage of the scaffold-free printing, the rapid tissue maturation and also generation, and also the cell the proliferation, also viability will be way much higher. If I can take those two benefits, it will be much better for human life and for making more progress. And for the biomaterial I'm going to choose here is cell fibrin. The reason why I want to choose a cell fibrin because it can controlling the shear force, because when you try to print the use of bioprinting, they have to follow the shear thinning property, which means when the force increase, the viscosity will start to decrease. And also the cell fibrin, it's a really robust material. If you just use Gelma, the gelatin mesoclate, is the degradability is really high. So when you mix with cell fibrin, they can lower their degradability, and also they have a good mechanical strength and also suitable for bioactivity. So the idea comes from here. At first, you have to make the spheroid-laden ink and put the cell fibrin solution. And after they put it together, and you can try to print the any organ you want. And for my research here, I'm gonna print a small cottage model. And after adding some spheroid cells into the whole model, and after culture, I will try to transplant in the mouse. And it's because of they also more accurate physiological model and also mimic in vivo microenvironment. And that's the conclusion I expect in my future plan. The incorporation of the cell fibrin, they can increase the viscosity of the polymer solution and also improve the printability without hampering the matrix production of the embedded cells. And also for the Gelma hydrogel, they can use as a cell matrix, provide a mechanical supportive microenvironment. They can be modified easily, mimic the native tissue. And also for the spheroid cell, they are loaded with a very high density close to native tissue and facilitate the cellular interaction. And also for the hybrid model can preserve their viability, also stability, also functionality, long-term in vitro. Okay, thank you for listening. That's all my research about. If you guys have any question, please let me know.
Thank you, Chia, for that wonderful talk. Very interesting research direction, and it was a pleasure to hear about it. So if anybody has questions, they can type them in the Q&A or in the chat. So I will get started and ask you a question here, Chia. So what do you think your primary first outcome is going to be that you're going to try and evaluate?
Oh, you mean the first outcome of my research?
Mm-hmm.
I would say, actually, right now, there are a lot of difficulty I have to overcome. For example, the spheroids, because I try to make a spheroid, but sometimes it's really hard to put it all together at the same size. But the first outcome, I think, if I make it successfully, it can be used after I make this scaffold. I can do the differentiate from the mesenchymal cells to chondrocyte and transplant into human. Transplant into mouse, and after I can transplant into human in the long term.
Wonderful. Any other questions for Chia? If not, I don't see any others. Rosemary, I see that your hand is up. Did you have a raised hand in the participants panel? Did you have a question or a comment? I saw that earlier. I'm gonna assume no. So let's go ahead. We can move on to our next speaker. Let's thank Chia for his excellent talk. We really appreciate it, and thank you for presenting in the middle of the night.
Thank you so much.
So our next speaker is Dr. Nathan Pogboom. He is co-director for the Dürfner-Lieberman Laboratory for Regenerative Rehabilitation Research and is a research scientist at the Center for Spinal Cord Injury Research and Center for Outcomes and Assessment Research at the Kessler Foundation. He is one of the recipients of a AR3T Career Development Award. And today he is going to be talking to us about his work titled Micro-Fragmented Adipose Tissue as a Potential Treatment for Shoulder and Knee Pain Caused by Rotator Cuff and Meniscus Pathologies. Nathan, I will turn it over to you.
Oops. Hello, everyone. I'm just trying to figure out how to share my screen. I think this is it here. Can everyone see that? All right.
Yep, all good.
So I will spare you the introduction since Nick's laid it out so perfectly. But yes, I'm Nathan Hogaboom here at Kessler Foundation in beautiful New Jersey. And I will be discussing two pilot studies that I conducted over the past couple of years here at Kessler that have led to a few grants. And yes, I will begin by, there we go, just kind of mentioning various funding organizations, Kessler, the Derfner Foundation, which has essentially sponsored the laboratory, at least its inception, Neidler, of course, the people at AR3T and the NIH, and the obligatory disclosure statement that none of the statements here represent the views of the national or the federal government. So here we just have a picture of our fledgling laboratory. It started with Drs. Gerard Malanga and Trevor Dyson Hudson back in 2017, I would like to say, with a donation from the Derfner Foundation. They hired me in 2018 as a postdoc, and now I have successfully transitioned into scientist, and our lab is continuing to expand. We hired a research coordinator and now are hopefully in the midst of hiring a postdoc and continuing to expand. Just to get into the actual presentation, some background about microfragmented adipose tissue. It has somewhat recently emerged as a potential treatment for musculoskeletal injuries. It's exactly what it sounds. It's adipose tissue that is slightly processed, and essentially the whole goal is to derive what are called mesenchymal stromal cells from the adipose tissue. And as many of us know, we all have probably an abundance of adipose tissue, especially after our pandemic experience. And so it's an abundant source. Everybody has it, and you can collect it from everybody. And simple processing will allow you to inject it into the actual tissue of choice. So the theory here is that these MSCs, they initiate a kind of not a rapid, but an amplified healing response in response to injury. And it does this through many different mechanisms, which have some support in the literature, including angiogenesis, anti-apoptosis, immunomodulation, as well as trophic effects. And so what we do here, you can derive MSCs a variety of ways. Some are more complicated and more heavily regulated than others. The way that we particularly do it is with a device called lipogems, or a system called lipogems. And there are many different ways to do it. This is not really a product advertisement. This is just the particular one that we have used and have had success with. So it is a device that is used to microfragment and cleanse the lipoaspirate prior to injection. And the key with this particular device is that it does not use enzymes or any particular additives. It is what they would call minimal manipulation. And this is very important because the FDA has pretty strict regulations over what you can do with biological tissues. And this particular device is FDA compliant because it is autologous, it is homologous, and it does not involve anything more than minimal manipulation. There are several other rules, but that's kind of the gist of it. This is kind of what the final product looks like. You go through, you wash it, you inject the adipose tissue into this particular device. It washes it, it fragments it, and this is what you get, this final product. It's just a nice kind of purified adipose tissue product. And the key with this particular product is that the stromal vascular niche is kept intact, which theoretically creates an environment in which the mesenchymal stromal cells can continue to live and continue their healing actions after injection into the tissue. And so now I'll move on to our different projects. So I have two projects to present. The first one is the use of autologous microfragmented adipose tissue as a treatment for shoulder pain in wheelchair users with spinal cord injury. So as some of you may know, those who are watching from my previous lab in Pittsburgh, overuse from wheelchair activities can cause rotator cuff tendinopathy, which results in high rates of shoulder pain in people with SCI. And this slide just shows kind of the progression of rotator cuff tendinopathy. You start with a normal tendon or a healthy tendon, and through repeated exposure to loads and micro traumas, ultimately what happens, and this is very common in wheelchair users, is you end up with tendon degeneration, which causes pain, limits function, and can ultimately result in a rotator cuff tear. Here's just a brief snapshot of anatomy of the shoulder so everyone knows what I'm talking about. What we're looking particularly at here is the supraspinatus, but really in wheelchair users, many of these soft tissue structures can degenerate over time and cause pain. Conservative treatments in this particular group, they often include therapy, medication, various modalities. If these options fail, then essentially you have two choices. You can either go through surgery, which has a long list of secondary complications, or you just live with your injury. And so really, the goal of this project was to kind of find a middle ground and find something that someone could use, after these conservative treatments fail, that would prevent or delay the need for surgery. So that is the aim of this project, which is to essentially investigate changes in shoulder pain and interference after treatment with MFAT in wheelchair users with spinal cord injury. And we're also trying to evaluate the safety, because the whole point of a pilot project is to kind of generate a treatment effect and work and evaluate safety so that you can move on to a larger trial to actually investigate effectiveness. One of our methods, inclusion criteria, a long list here, but I won't list everything, but essentially we're looking for people who use a wheelchair because they have a spinal cord injury, a chronic injury, and they have chronic shoulder pain caused by rotator cuff disease in spite of 6 months of conservative treatment that I mentioned, the treatments that I mentioned previously. And they had to have had at least moderate to severe shoulder pain, which is equal to at least a 4 out of 10 on an 11-point numerical rating scale. And rotator cuff disease was defined as pain over the anterior shoulder with direct palpation and pain at the shoulder with provocative tests confirmed via ultrasound. Exclusion criteria, we wanted to avoid people who had prior lipogems treatments and other treatments such as corticosteroids or PRP, as well as any contraindications to the procedure, which is infection, coagulopathy, or taking anticoagulants. So a little bit of a summary about the actual process of the lipogem system and what we did. Lipoaspirate is harvested from the abdomen and transferred to the actual device. You can see it here being withdrawn from the abdomen and inserted into the actual device. The lipogems product is then injected under ultrasound guidance into the degenerated shoulder structures. And in this particular study, everyone had their supraspinatus injected. Really, it was any kind of shoulder structure that showed some kind of degeneration. So that could be the glenohumeral joint or a acromioclavicular joint. infraspinatus, subscap, any of the soft tissues that showed degeneration were injected, but everyone had their supraspinatus injected. Here's just a brief video of the actual injection. It'll play, it is playing. So the physician, who in this case is Dr. Malenga, is repeatedly needling the tendon in order to kind of generate some channels in there to inject the actual product. And you'll see that, I believe, coming up. You'll see kind of a bolus go in and expand the tissue a little bit. Yep, so this is what it looks like under, yep, there you go. The injection occurred there. You can see the bolus, and it actually infiltrating the tendon and the joint. Data were collected at screening, the day of treatment, and at various time points post-treatment up to a year. We took physical exams, numerical rating scales, various pain scales of pain interference, as well as MRI and ultrasound images. So for this particular study, we recruited 11 people. One had to withdraw because he decided not to actually join the study after he was recruited. One person was excluded due to low pain scores and inability to comply with the protocol. And another person was excluded after receiving alternative injections for shoulder pain. There was one individual who passed away between weeks 24 and 52, but this was deemed unrelated to the study treatment. So on to the actual results of the study. The results of the injection in terms of numerical rating scale, which is the 0 to 10 point scale, 0 being no pain, 10 being maximum pain possible. Overall, it showed a marked decrease in pain over the course of the 52-week trial. The black line here, the solid black line indicates the mean score, whereas dotted lines are actual individual scores. So you can kind of see that everyone generally trends down. There are some people who show some initial decrease, but then increase a little bit towards the end of the trial. We're kind of, the interesting thing about this study is we did show kind of a varied response at various time points. So the next phase will actually, I think, allow us to tease out some of those anomalies and see why certain people reacted some ways and why certain other people reacted other ways. Here's just another measure of more functional pain. It's called the Wheelchair User Shoulder Pain Index. It asks how different wheelchair activities cause pain. And so whereas the numerical rating scale is just kind of a composite, how's your pain over the last week, this is how do these various activities cause pain. And so we see a very similar response, where on average, everyone decreased over the course of the 52-week trial. Some people decreased a little bit and remained elevated. Some people decreased and then rose up back close to baseline. So you're seeing a kind of a common trend here. The same thing with the brief pain inventory, which is a measure of pain interference. Similar response. We also collected some information. We asked them, it's called the Patient Global Impression of Change Scale. It is essentially, we asked them, how does your overall status change as a result of this particular treatment? So this is more of a global measure of change. And most people said they felt very much improved afterward. Some people said much improved. One person said minimally worse. And this kind of comes back to that, the need for collecting more data, collecting a larger sample so that we can kind of tease out why some people reacted poorly and why others reacted much more positively. So that was project 1, a brief snapshot, and I'll move on to our project 2, which is a completely different joint. We're looking here at the knee. So it's called Use of Autologous Micro-Fragmented Adipose Tissue as a Treatment for Meniscus Tears. And again, This was a pilot study. That is, the whole goal was to kind of generate treatment effect for this particular treatment, as well as evaluate safety. But I'll get to that. So the meniscus, and here's a nice, beautiful anatomical picture of the meniscus. The knee is a very complex joint with many different tissues that do very different things. And the meniscus is one of the most common musculoskeletal injury locations in the human body, and it can have several consequences, namely the generation of or the acceleration of arthritis. What you often happen is after an injury like the meniscus injury, you see generally several years down the line, you start to generate markers for osteoarthritis, and this happens with pretty much any age group, whether you're in your earlier mid-20s or all the way up into your 50s, 60s. So this is a very common injury that can have several pretty long-term consequences. And the issue is that just like with the rotator cuff, the treatment options, the non-operative treatment options, if they fail, then your next option is essentially to live with it or to get surgery. And surgical outcomes for meniscus tears are not generally the best. And again, you don't really, if you can avoid surgery, you want to do that just because of several complications that can occur during surgery. And so this is another potential option that can delay or prevent the need for surgery in the future. A bit about meniscus anatomy and why it is so difficult to treat. The vascularity of the meniscus, which is an indicator of healing potential, is lower in the medial portion compared to the periphery. You can see, so that's why peripheral meniscus injuries tend to heal spontaneously, but intermeniscal tears simply are much more challenging to heal on their own. And so the goal here essentially is you are trying to generate a hole, essentially, an artificial channel in the meniscus that goes from the periphery to the inner portion, which would allow for the infiltration of healing factors into the inner part of the meniscus. And you're also trying to generate an inflammatory response, because the body's natural response to injury is inflammation. It is a completely natural response. The problem is when there is an overreaction or an abundance of inflammation, that it becomes degenerative. And so you are, by doing this, you are trying to initiate an inflammatory response, but then you inject microfragmented adipose tissue, which can aid in kind of suppressing the pro-inflammatory response that can lead to degeneration and further injury, and initiating a more anti-inflammatory and healthy response. So the goals of this pilot study were to, similar to the previous study, were to investigate changes in knee pain caused by meniscus injury after treatment with MFAT. And we're using the same numerical pain rating scale, 0 to 10, as the prior study, but we're doing a more specific knee pain and function scale for this particular study. It's called the Knee Injury and Osteoarthritis Outcome Score. It consists of 5 different subscales that look at symptoms, pain, and various functional activities, as well as quality of life. And we're also looking to evaluate safety of this particular treatment for knee pain caused by meniscus injury. Methods, inclusion criteria, I won't read all of them, but essentially we're looking for knee pain associated with symptoms of torn meniscus that has lasted for at least 3 months with various positive physical exam signs for meniscus injury, and MRI or arthroscopic evidence of a meniscus tear. They also had to have failed conservative treatment, which is a combination of pain meds, physical therapy, corticosteroid injection, or hyaluronic acid injection. Exclusion criteria, we're looking for people that have that do not have diffuse knee pain or pain that is caused by something other than an injury, chronically locked knee, a history of knee surgery, assessment at screening that they would need something, that they would absolutely need surgery instead of this particular treatment, as well as treatment with other kind of PRP, cortisone, or hyaluronic acid, and also malignancy within 5 years. So data were collected at screening, the day of treatment, and months 3, 6, and 12 post-treatment. We did physical exams. The primary outcomes here were essentially the numerical rating scale scores and the KOOS scores, the knee injury and osteoarthritis outcome score, and each of the subscales. And I'll show you those data in a second. Onto the results. So we collected 20 people were actually enrolled and went through the trial. One person had an injury to their other knee, and so they ended up being excluded for that. That was unfortunate, but we ended up with 19 people. Most subjects had complex tears in the medial meniscus and presented with moderate arthritis. No serious adverse events were noted, only minor responses to the lipoaspiration and the injection. And these responses resolved within a few weeks. One person did have some signs of infection, but that was treated with antibiotics, and they were fine. So onto our outcome measures, we showed decreases in average pain, numerical rating scales. We showed decreases at all time points post-treatment up to 12 months. And those really didn't change too much between 3 and 12 months. We saw very similar responses in the KOOS subscale scores. You can see we have improvements in symptoms, pain, function during activities of daily living, function during sports and recreation, and quality of life. All showed kind of similar patterns. And they tended to increase very rapidly and then level off after 6 months. I think what will be very interesting, and I know that there's interest in our lab for doing this, is to carry these measurements out to 18 months, 24 months, and longer to see if there are actually, if they revert back to their baseline or if those improvements are maintained long term. So on to conclusions. For just overall conclusions for projects 1 and 2, I didn't separate them out because they're kind of similar. But MFAT appears to be safe and potentially efficacious treatment for shoulder pain and knee pain caused by rotator cuff and meniscus injuries. And we know this because pain and function in both studies improved over the course of the trials, and there were no serious adverse events that were reported. There were some people who did not respond very well, and as I said, we need to collect more data, larger samples, and preferably conduct randomized control trials to establish efficacy. These studies have resulted in 2 peer-reviewed manuscripts. One was recently accepted, and one was accepted last year into international orthopedics. So future directions. As I mentioned previously, we did receive funding for project 1, that was the rotator cuff and wheelchair users. We received funding to conduct a randomized controlled pilot trial, which is currently underway. And we are comparing MFAT with corticosteroid as the control. This funding was provided by the New Jersey Commission on Spinal Cord Research. For project 2, we received funding to conduct a multi-site randomized control trial in active duty military personnel, which is also currently underway. We are comparing MFAT to normal saline as the control. And this was supported by the Geneva Foundation and Uniformed Services University, specifically the Musculoskeletal Injury Rehabilitation Research for Operational Readiness, which is also called MIR. It's a massive consortium of a number of different projects, the ultimate goal of improving rehabilitation outcomes for active duty military personnel. We were also awarded funding to conduct a pilot project, which will hopefully yield many different future avenues of research. And this is looking at chemical and cellular characterization of hemarthrosis after traumatic knee injuries and active duty military personnel. This was also supported by the Mirror Group. And one thing that we have been successful in doing over the past couple of years is really trying to develop methods and expand our laboratory's infrastructure to collect biomarkers, which we'll use to measure changes in response to treatment. And this is very important because we've been doing a very good job, and really the field as a whole has been doing a good job of measuring the kind of subjective response to the treatment. So how the participants feel, their pain and their improvements, their self-reported improvements in function. But what is missing really are more objective measures of pathology in response to treatments. And so we have a very solid imaging facility here, and we are developing our T2 mapping methods for MRI. We just received the shoulder coil, and we are I'm currently preparing a grant to actually study that in wheelchair users. We have ultrasound shear wave elastography. We have a few different imaging modalities that we're using to quantify changes over time. And we're also expanding our capabilities to look at markers in blood, synovial fluid, and other tissues. These are very important because essentially you're trying to capture a very holistic understanding of the response to treatment and disease. You have imaging, which gives you kind of structural and biochemical understanding of what's going on. You have the self-report measures, so how the participants and the patients feel when they receive this. And then you have your more chemical markers, which really are the kind of underlying cause of the structural changes and the subjective responses. And so by collecting all these different markers, you're generating a very complete and holistic picture of the response to treatment. My obligatory reference slide. And thank you all to those who are watching right now. Thank you to AR3T and the various members, as well as Drs. Dyson Hudson and Jerry Malenga, who have supported me throughout my postdoc and now my tenure as a scientist. So any questions I'd be willing to answer.
Awesome, Nathan. Thank you so much for that excellent talk. It's really great to see this type of clinical research going on, especially with these cell therapies. It's very much needed, and seeing it taken out to a full year is really great and exciting. So we have a couple questions. First off, to everybody, I'm going to plug the series and put in the chat a link to sign up for the next one. So I hope that you've enjoyed this series so far. Please sign up. We have a great session about a month from now. All right, Nathan, we have a couple questions for you. The first one is from Brand Fask, and the question is, for either injection, what was the healing time and was post-injection rehab considered?
Yes, so, excuse me. For the first study, the rotator cuff study, we actually had a pretty defined post-injection rehab protocol. That was guided by the literature, excuse me. It essentially consisted of stretching initially and then moving on to strengthening exercises. And it was staggered, so the participant was instructed not to do anything strenuous for the first 24 hours after injury, and then slowly ramp up the rehab protocol, starting with stretching for the first month and then moving on to strengthening exercises thereafter. So it's fairly well structured. I will say that in this group, the people who, it's kind of hit or miss, who actually followed the rehab protocol. Most people did it for a little while and then stopped doing it, or they just didn't do it altogether. Some people actually did it all the way through. Yeah, it was kind of varied. And so it's hard to say whether or not the treatment response was due to therapy or the injection. It was most likely because of the injection, because many of these people had gone through physical therapy and had done a number of conservative treatments that failed. And also many of them just didn't do the therapy. So it's very likely that it was the injection, but that's where kind of the randomized control trials come in. The second one, there wasn't the meniscus, the knee injury study, there was not a structured rehab program. It was more, they had to rest for, I believe, a week and then kind of slowly ramp up their activities so that by the end of 6 to 8 weeks, they were back to their normal activities. So it was much less structured, but there was some time to allow for healing, which was about a week.
Excellent. So there was one quick secondary question, pretty similar, where Fabricia Ambrosio asks what your recommendations regarding weight bearing immediately after injections were, and how loading. So pretty similar. But,
yeah.
Did you?
Yeah. Pretty similar, but very different, especially in wheelchair users who, unless you're using a power chair or you have a helper, you're essentially required to bear weight in your arms, whether through transfers or wheelchair use. And so that's somewhat unavoidable, but it was more of a you know, be cautious. Don't go out and, you know, wheel up a mountain or something like that afterward. Just do the very minimum, and also there was an issue with, we used anesthesia, so you know, you're going out and your shoulders all anesthetized. You don't really have that pain sensation, so there's always the chance of taking things a little bit overboard. So we just really tried to caution them and say, you know, be very cautious. Do not wheel too hard, wheel too far. Do whatever you need to essentially just accomplish your activities of daily living. For the meniscus study, weight bearing was limited. They were recommended to use crutches afterward for the first week. And then after the first week, they could begin to bear weight on their legs and ramp up to full activity.
Awesome. So next question is in the Q&A. It says, hi, greetings from Dubai. I am Dr. Suad Trebinich, physiatrist. Thank you very much for the interesting lecture. Question is related to inclusion criteria for rotator cuff. Did you include patients without tear, in parentheses, tendinopathies, or with tear, in parentheses, the size of tear?
So in this group, we didn't really have an inclusion criteria of tear. But in our particular study, essentially you had to have rotator cuff disease and pain caused by the disease. In our particular study, everyone had a tear. They were all partial thickness tears, so no full thickness tears with retraction. And the sizes varied. The sizes and locations varied. And I don't have that data on me right now. I'd have to kind of look through everything. We didn't actually collect size anywhere, really. I think it would be an interesting variable to actually collect. We do have size information on some individuals. We collected it via ultrasound, but we did not really record that on any of our case report forms. But I do think that would be an interesting variable to collect in the future.
Great. So next question, Hong Shui Li asks, what's the possible mechanisms? Is this because of the cell integration or paracrine effects?
Very good question and a very hard question to answer. The mechanism, I mean, it could be really one of many several mechanisms. The act of actually needling the tendon has been shown to initiate some kind of healing response and improve outcomes. Right there, the potential mechanism behind there is you are initiating an inflammatory response. You're essentially causing micro injuries in the tendon. And tendons and menisci, they're pretty avascular compared to, say, muscle, skin, or other tissues. So they don't heal very rapidly. And so by actually creating perforations in the tissue, the theory is that you are allowing healing factors to infiltrate the tissue that would otherwise normally not be able to get in there very easily. So that's one potential mechanism. The other potential mechanisms are the actual cells within the tissue that are causing, not necessarily causing, but attracting healing factors to the site of injection. So you inject the MFAT into the tissue, and the theory is that it actually stays there. And we have some ultrasound images that are very intriguing that actually show some bullae of the MFAT in the tendon several months after the injection. And so the thought is that the MFAT stays there, and because it's kind of harbored in this stromal vascular niche, the cells kind of stay there and they attract healing factors and they naturally heal the site of injury. There's actually hasn't been any proof of that. Like I said, we have some interesting images that we could explore in the future, but at least that's one of the theories.
Very interesting line of work for sure. So we have one last question in the last minute. We have heard that there is a regenerative rehabilitation postdoc fellowship program at Kessler, and we were wondering if you could briefly tell us what that is, and we were wondering if perhaps you might be recruiting and wanting to advertise to the group.
Sure, I will tell you because I was a postdoc here. I'd say it's a bit of a non-traditional postdoc. You come here and you participate in one of our many different studies. You get so you have a lot of research work here in the lab, but you also get to, you have the opportunity to go to Dr. Malenga's clinic and actually see a lot of these therapies and interact with the patients and the physicians who are doing these treatments. And you also have the opportunity to, for example, go to the Mayo Clinic, paid for by AR3T, to go to a regenerative rehab symposium and learn about various regenerative rehab therapies being used over there and across the country. So in short, you have kind of a wide variety of opportunities and experiences that would be fairly unique to other postdocs, I would say, all within the realm of regenerative rehab. And we are always advertising for postdocs. So if you are interested, you can feel free to reach out to me or Drs. Dyson Hudson or Malenga, and we will certainly meet with you and discuss the potential for a postdoc.
Outstanding. Well, with that, we're right at 12. So let's, again, thank you to both of our speakers today for excellent talks. Thank you for the attendees for coming and listening and participating, asking questions. We hope that you will join us a month from now for the next session. If any of the ICRR members want to stay on, we'll have a brief ICRR meet and greet with Nathan. Everybody else, thank you so much.